Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Have you ever been in, a healthcare situation, maybe for yourself or someone you care about, and you just get that feeling, am I really in the right place for this? Am I getting the right care?
Mm-hmm.
It's a common feeling, I think, often unspoken. Today, we're going to dive deep into something critical, but maybe a bit hidden in healthcare that really affects that feeling. Avoiding what are called wrong referrals in general surgery.
Right.
And what's kind of surprising is how much this seemingly small administrative thing can actually snowball into serious patient safety issues and just drain resources.
It's a huge drain, yeah.
We're talking about a problem that, in some systems, it can be like 20, maybe even 30% of specialist consultations being unnecessary.
That's a staggering number when you think about it.
It really is. So our mission today is to unpack what's essential here, about optimizing these surgical referrals. We want to offer some maybe surprising facts and definitely some practical insights. Because these wrong referrals, they don't just waste time for everyone, clinicians, patients. They can actually delay necessary care, sometimes life-saving care.
Absolutely. Critical delays.
And this advice, it's especially relevant if you work in busy surgical units, maybe a district hospital or those bigger tertiary centers. But honestly, the principles, they apply pretty broadly.
You've really hit on something fundamental there. That feeling you described, that patient anxiety, it often comes from a system that's just not quite perfectly tuned.
Right.
And that's exactly what we're digging into. The critical nature here, it really goes way beyond just being efficient.
Mm-hmm.
Our goal today, it isn't just about, ticking boxes or avoiding mistakes. It's fundamentally about ensuring timely, accurate, and really targeted surgical help.
Targeted, yeah.
When we get this right, it makes a huge difference for patients, obviously, but also for the providers, the surgeons, the teams. So yeah, we're going to share insights that are, I think, a mix of practical steps you can take tomorrow and also some broader strategic tips that general surgeons can use, right now to try and avoid accepting those inappropriate or maybe just inaccurate referrals.
Okay, let's unpack this then. So the first step, pillar 1. It seems like it's all about laying down some really clear ground rules, setting the foundation.
That's right.
But what does clear really truly mean here? I can imagine, some clinicians might feel, oh, great, more rules, or my cases are unique. How do you actually get buy-in?
That's a really important question, because clear here isn't just about, more bureaucracy. It's about changing a vague, maybe this needs surgery, into a definite yes or a definite no.
Okay.
There's that saying, clarity is kindness, right? In healthcare, it's also efficiency. It's safety.
Yeah.
And the real insight, I think, the way to get buy-in is that these aren't rules handed down from on high. The best guidelines, they're built collaboratively with the very teams doing the referring. Your emergency department, internal medicine, primary care folks.
Right. So they have ownership.
Exactly. That mutual ownership, that's what makes them stick. And specifically, these guidelines need to spell out really clearly which conditions need that urgent surgical look. Classic examples like acute appendicitis, bowel obstruction.
The obvious ones.
The more obvious ones, yes. But just as important, clarifying what's not appropriate for a surgical referral, like, abdominal pain where there's a clear medical cause found already.
Okay.
And the final piece, absolutely crucial. Make these guidelines easy to find and easy to follow, not buried in some 100-page manual nobody reads.
Got it. Accessible.
Yeah.
So that clarity sets the stage, but, we've all seen situations where the best rules kind of fall apart if the human interaction isn't there. It's not just about what's on paper, is it? This brings us to pillar 2, I guess. Communication and triage in action. How do people actually interact?
Couldn't agree more. You nail it. Strengthening that communication with the referring teams is just vital.
Okay.
I often think a good referral note should be like a detective's summary. Give us the whole picture, not just, a single clue.
Right. The why.
Exactly. And direct communication, picking up the phone, using secure messaging, especially for those urgent or maybe borderline cases, it's paramount.
Yeah.
I've seen it so many times. A quick 2-minute call can clear up a referral that might have otherwise wasted hours, caused patient anxiety. Saves everyone time.
It's often the fastest tool we have, honestly. And building on that communication is having a structured triage system. Pillar 2.
Okay, structured triage, what does that look like?
So this means putting a system in place. Maybe it's led by an experienced nurse, maybe a surgical registrar, a senior resident or junior specialist. to actually assess those referrals before they get formally accepted onto the surgical
A
list.
gatekeeper, almost. A knowledgeable gatekeeper, yes.
Yeah.
Using standardized forms, maybe digital tools, to make sure there's clear clinical justification.
Right.
Then categorizing them. Urgent, semi-urgent, elective.
Yeah.
And acting on that. And, importantly, if a referral just isn't appropriate,
Yeah.
having a process to politely reject it. Giving clear reasons why. And ideally, pointing the referrer towards the right specialty if surgery isn't it.
Okay. Politely rejecting.
Yeah.
That sounds potentially tricky. You mentioned potential friction earlier. How do you handle that? Make sure it's a learning moment, not just a no.
That's the art, isn't it?
Yeah. And thinking about prevention, too. Moving beyond the surgical team's process. What about empowering the referrers themselves? Pillar 3, maybe. Getting things right before the referral even happens.
It absolutely is pillar 3, and it links directly to avoiding that friction you mentioned.
Yeah.
So many inappropriate referrals, honestly, they just come from an incomplete initial workup.
Ah, okay. Not enough info.
Exactly. Think about it, sending someone to surgery with just tummy pain. It's like, well, asking a mechanic to fix a car noise without knowing anything else.
Right.
Pretty much. So empowering referrers means encouraging them to do those basic, often quick investigations first. Unless, of course, the patient is really unstable.
Like what kind of investigations?
Simple things, often. A basic urinalysis can sometimes rule out a surgical emergency, if you suspect a UTI, for example. Abdominal x-ray, maybe an ultrasound for certain pains, basic bloods like a full count, and CRP.
Okay.
It's about setting some minimum expectations for imaging or labs before the surgical consult happens again, emergencies aside.
Right. Unless it's critical.
Precisely. And a huge part of this empowerment is, well, education. Educating the referring clinicians.
How do you do that effectively?
It's not about pointing fingers, it's collaborative learning. Things like regular multidisciplinary meetings, case reviews with the departments that refer frequently, like Emerge or internal medicine. In those sessions, you can highlight common inappropriate referrals, explain why they weren't quite right for surgery, but crucially, also share examples of really good, high-quality referrals.
Ah, show them what good looks like.
Exactly. Foster that understanding, encourage questions, and one more thing here, encourage the use of decision support tools.
Like scoring systems.
Yeah, things like Klendel scoring systems. The Alvarado score for appendicitis is a classic example. They can help make the decision a bit more objective, less ambiguous. They can be built into electronic records or even just pocket cards.
That's interesting, bringing objective tools into it. It really sounds like a constant loop of improvement is needed here, everyone learning. That leads nicely into pillar 4, I think, feedback and professionalism.
You got it. That constant loop is exactly right.
Yeah.
And a vital part of that loop is providing feedback. Pillar 4.
Okay.
When a referral isn't appropriate, giving timely feedback back to the person who sent it is key.
But constructively, right?
Absolutely. Frame it as a learning opportunity, never putative. Even just a quick note or a brief chat explaining why it wasn't accepted can really cut down on repeat errors.
Makes sense.
And feedback goes both ways, remember. The surgical team should also feel comfortable giving feedback if, say, a handover was poor or documentation made triage difficult.
Okay, two-way street.
Definitely. And alongside feedback, documentation. Document everything clearly.
The medico-legal aspect.
Partly, yes, but also just for good continuity of care. You need the referral note, the triage decision, records of any communication. It's crucial, especially if things change for the patient later.
Right.
And finally, under this pillar, professionalism. Being respectful, but also assertive.
That can be tough, rejecting a colleague's request.
It is challenging, especially when things are busy and stressed. But
Yeah.
you have to remember, unnecessary consultations don't just strain resources. They can potentially compromise care for patients who do urgently need that surgical slot or attention.
So be polite but firm.
Exactly. Polite, firm, offer alternatives if you can. Maybe cardiology's a better fit, or have you considered X? And if you're unsure or there's conflict, don't hesitate to escalate to a senior colleague.
Good advice. Okay, so we've got clear rules, good communication, empowered referrers, and this feedback loop with solid documentation and professionalism. That's a lot. How do we actually know if it's all, working? How do you measure success?
Pillar 5. That's the final piece, Pillar 5. Continuous improvement through audit. You hit the nail on the head. How do we know it's working?
Yeah.
You audit. You review the referrals regularly, maybe set up a monthly or quarterly review.
Looking for what?
Patterns. Are inappropriate referrals clustering from one area? Is
Yeah.
it always about a specific condition? You use that data, that information, to tweak your pathways, refine your training, address the specific issues you're seeing.
Data-driven improvement.
Precisely. And importantly, use that data to celebrate wins, too. Show the team where things have improved, but also use it to highlight where problems persist. It really closes that continuous improvement loop.
Okay, that makes a lot of sense. Closing the loop with data.
So really, when you pull it all together, avoiding these wrong referrals in general surgery, it's not about finding one single solution, some kind of magic bullet.
No silver bullet, yeah.
No, it's this combination, isn't it? Clear protocols, yes, but also that effective communication, ongoing education for everyone involved, and that proactive feedback culture. When you foster that collaboration and really empower good clinical judgment at every step, that's how surgical teams can genuinely streamline patient care. They can actively avoid the waste, the inefficiencies, and importantly, the risks that come with unnecessary consultations.
Right.
The bottom line, I suppose, is that getting referrals right benefits everyone.
Yeah.
It ensures patients get that timely, accurate, targeted surgical care when they truly need it.
That's really powerful. And what strikes me is how, like you said, none of these steps are maybe individually revolutionary. Clear rules, talking to each other, learning, but putting them together systematically seems to have this profound impact on flow, on safety. It's not just avoiding mistakes, it's really optimizing every interaction.
That's a great way to put it, optimizing interactions.
And it leaves me with a thought, maybe for you, the listener, to consider. How might taking these principles, this clarity, this collaboration, this continuous learning loop, how might that not just change surgical departments, but maybe reshape efficiency and patient outcomes across all kinds of specialized medical fields?
Interesting question.
Think about that ripple effect. If everyone got this right everywhere, what would that look like?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.